Hello there. I am Dr. Darshan Raninga and I am going to talk about obstetrics and gynecology as a career. So basically obstetrician and gynecologist, or let's say commonly known as a gynecologist. We doctors are specialists that deal with primarily functions and problems of reproductive parts of the female, right? What we deal with, the reproductive parts of the female, their functions and their problems, right? Now if you if you look at the career, or if you look at the course, or if you look at the workspace, there are three different parts of our career, or there are three different parts what we practice. The first one is obstetrics. Obstetric part deals with pregnancy and parturition. The gynecology part deals with the disorders of female reproductive system. Those also includes cancers. And the third and very important part is reproduction, in which we deal with both contraception and infertility. So there are three different parts that we deal with basically in India. I want to tell you something about the various specialties and super specialties in the obstetrics and gynecology. If you look at other specialties like MD medicine or MS surgery, there are clear cut demarcation of super specialties, that one person is doing this, then if he wants to do a super specialization in that particular course, they can do another 3-year course of doctorate of medicine, that is DM or MCH, right? But what we have in obstetric and gynecology, we also have those super specialization course, but it is not that well demarcated. For example, if you have done an MCH in oncology, gynecological oncology, so okay, you basically deals with the cancers, but as a gynecologist you should always knowing other things too, because in India the concept is not that much clear cut that yes, if you have done this particular specialty as far as the obstetric and gynecology is concerned, it's not well demarcated. Another thing is that we as obstetrician and gynecologist, we have different stratas of milestone, or we can say milestones in our career. So if I tell you that if a MD medicine or a MS surgery who just have graduated or post graduated and have done like 1 or 2 years of senior residencies, they can do almost all things at their part, right? For example, if you see MD medicine people, yes, they can treat malaria, they can treat typhoid, yes, they can do that. At very great extent, they don't need a super specialist, right? And when they actually need a super specialist, then their work is stopped from that particular point. But what in obstetrician and gynecologist, we have different milestones, we don't have those clear cut demarcation. So I know it's little bit confusing to you, I will explain you with the example. So if you talk about a specialty, okay, we are gynecologist, an obstetrician, If the obstetric part is concerned, a general or a basic obstetrician and gynecologist can do what? Basic ANC follow up, look for any high risk in the pregnancy. The gynecologist can do a vaginal deliveries and cesarean sections with low risk. They can do and even read the basic ultrasounds. Right, a basic, as far as obstetric is concerned, a basic gynecologist can do these things. But as I have already told you, there is no clear cut demarcation. If you are practicing as a basic gynecologist, right, and once you encounter deliveries or the pregnancies with uncontrolled blood pressure and sugar, right, now we don't have this particular demarcation of dealing with high risk pregnancy or dealing with different kind of cases. At that time you will realize that you might lack the competency in treating this kind of high risk pregnancies uh, in well mannered plan. Okay, whenever you actually see a patient of uncontrolled blood pressure in your ANC clinic or in your antenatal visit, you might not be knowing what to do next. Right? You have done a post graduation or senior residency where you are facing the cases, most of the cases are what? Of a normal kind of procedures or a normal routine cases. But once you get this kind of cases, yes, you can do a basic management plans. For example, if you have a patient came to you with the very high blood pressure, preeclampsia, yes, you know that how to start the magnesium sulfate, but you might not be knowing the perfect dosing, or you might not knowing the neuroprotectant dose of magnesium sulfate for the fetus. So I hope you understand what I'm trying to tell you, because dealing with this kind of cases requires a different kind of training than just a basic obstetrician and gynecologist. For example, if you encounter a case, a obstetrician, a pregnancy case with severe medical disorders like myocardial infarction, or like let's say any valvular heart disease, it's okay, you know the basic management. But if you thought about a well planned and advanced management of these cases, you might be lacking that expertise, or you might not have a confidence in your treatment for this kind of patient. This thing is very very important, and this thing is faced by almost all newcomer gynecologists and uh, uh, new doctors who actually have started their private practice, or they are doing some teaching jobs in the medical college as a professor or assistant professor. So what I'm trying to tell you is this: another thing, if you, for example, if you get a patient with congenital fetal conditions, right, you might not be knowing the proper protocol to follow, how to deal with these kind of patients. It's okay, you can get the guidelines written on the net, or there are various guideline defining bodies like RCOG, SEOG, ASHRAEs. Yes, you can get the guidelines, but to just read that guideline and apply your management, these are total two different things. You can't just read the guideline and start treating the patient, because you need certain amount of experience in dealing with this kind of pregnancy, and you have to work under some specialist or a doctor who is well experienced in dealing with those things. But most of the time, most of the students or most of the newcomer practicing gynecologist or basic gynecologist might not be knowing whom to contact to deal with those cases, right? It's same about critical care also. It's okay you have done a perform a cesarean section which landed in postpartum hemorrhage, right? But most or many of us don't have a basic critical care or ICU unit in their private hospitals. Okay, so what I'm trying to tell you is it's a little a lake of demarcation where we actually stop our treatment and to contact a specialist. So this is going on right now in India, right? For example, if you see a patient, you are doing you are doing hundreds of cesarean sections, right? You have done hundreds of cesarean sections in your post graduation or in your senior residency. But when you actually encounter a case with severe PPH and you have no option then obstetric hysterectomy, I bet that many gynecologists are very comfortable doing obstetric hysterectomy. So there is no clear cut demarcation. Still, we are doing our cesarean section because we know that we don't need obstetric hysterectomy in much cases. We are performing cesarean sections. But when you are performing cesarean sections in your private practice, you must be knowing how to do a obstetric hysterectomy because anytime any case can become critical, right? So again, we don't have that demarcation, right? If even we don't know obstetric hysterectomy or we don't have a confident or confidence in doing that surgery, many gynecologists are doing cesarean sections on routine basis. So at the time they get in problem, right? Many students or many people who are practicing actually and doing various procedures and surgeries, they can't reach to the posterior peritoneal or retroperitoneal space, right? Despite doing thousands of surgeries, they don't know where to reach for internal iliac artery if it is needed to be ligated, right? So if you want to do internal iliac artery ligation, you need to reach retroperitoneal. But again, what I told you, there is lack of clear cut demarcation. People don't know how to do the ligation, but still they are continue to do cesarean sections. And uterine artery embolization, these all things are needing another kind of training than just a basic gynecology, right? Other parts are associated with fetal medicine like prenatal diagnosis, amniocentesis, CVS, that is chorionic villus sample, intrauterine blood transfusion, fetoscopy, antenatal scan, detailed, all these particular aspects, these are included in the fetal medicine. But most of the time we don't have that particular access to that fetal medicine fellow, but still we are doing our practice, right? So the crux of my lecture is that you people or a gynecologist needs more training even after their basic course or their basic post graduation. They need a special training on special problems under an experienced fellow who have a vast experience of doing these procedures. So what I'm trying to tell you, just doing a graduate post graduation is not enough, right? If we talk about gynecology, general gynecology, everybody does a everybody does a consultation, a treatment, medical treatments like disorders, commoner disorders of PCOD, medical treatment for disorders of menstruation like dysmenorrhea, menorrhagia, right? Infections, and many gynecologists are able to perform simple hysterectomy, vaginal, abdominal both, and many gynecologists are able to do a basic ultrasound in which they can clearly identify the structures and the problems into that. But there are population or the people who don't know how to do or perform a laparoscopic surgery, right? Diagnostic laparoscopy and diagnostic hysteroscopy are the very fundamental endoscopic surgeries that a gynecologist must master. Laparoscopic hysterectomy, myomectomy, ovarian surgeries, ovarian drillings, hysteroscopic polypectomy, myomectomy. All these surgeries are very important surgeries, and these surgeries are now the main part of the gynecological practice, and they are in mainstream today. Today, um, there is no trend of doing abdominal hysterectomy. Either you do it NDVH, that is non-descent vaginal hysterectomy, or you go for laparoscopy. For simple hysterectomy, you are doing a abdominal route. It's not good for the patient, right? So again, what I'm trying to tell you, maybe you know how to do abdominal hysterectomy, but to learn the laparoscopy, you need another training, right? There are certain advanced ultrasound uh, diagnosis that you can perform if you know how to do a proper ultrasound. Like you can perform an ultrasound examination, you can identify endometriosis, ovarian cyst, fibroids, adenomyosis, ovarian studies. All these things are very important part of your gynecological practice. And if you master this practice, you are becoming a more and more competent doctor, right? One surprising thing I have noticed is I have known certain postgraduated people or who have done their post graduation in gynecology with gold medal. They are very brilliant, right? But they lack basic knowledge about the hormonal functions. Let's say a person or a patient comes to you with a simple cyst in their right ovary, right? Now, what you expect? How much estrogen level the patient should have? The simple cyst may be a dominant follicle too, but how to know this thing that whether it is a simple cyst or a dominant follicle? This basic difference is well understood by the serum estrogen level of the patient. But many of us, many of the gynecologists, gold medalists, actually lack these basic hormonal things or a hormonal interplays that is very crucial for an gynecological practice, right? To deal with follicular stimulation hormone, luteinizing hormone, estrogen, progesterone, HCG, all these different kind of hormones are very important part of the gynecology, and you must be dealing with these particular uh, hormones day to day life. So you need to well training in understanding these particular interplays and how to make your diagnosis more correct by ordering these investigations. But a basic gynecologist might be not knowing what is the importance of these hormonal problems or hormonal levels, right? Now, another very important aspect is reproductive medicine. Reproductive medicine is very important thing, and is it is becoming a mainstream in today day-to-day life of the gynecologist, right? A simple gynecologist can do a ovulation induction or even a intrauterine insemination of basic type. But to deal with or to treat a patient with infertility or advanced infertility, you need to do a training in infertility to get those particular uh, understandings of different, let's say for example AMH is very important investigation. Most of the gynecologists do not perform serum AMH level for their infertile patients, right? Serum AMH level is very very important investigation, but to know how to investigate or how to order this AMH and how to interpret the results needs training. It is not well understood at the level of basic gynecologist. You need to understand ovarian reserve, you need to understand PRP, that is platelet rich plasma infusion in the uterus, subendometrial or uterine cavity. You need to understand stem cells for a thin endometrium in fertile patients. You also needing to know about different GnRH agonist and antagonist compounds that are available. These drugs are very very important for a gynecological practice, but I have seen a very few people using these particular drugs, GnRH agonist and antagonist, because they lack knowledge and experience in doing in applying these particular drugs, because they are very helpful if they are used right. For every adenomyosis, for example patient have a adenomyosis, uterine adenomyosis, she has a complaint of menorrhagia, dysmenorrhea, right? What you will do? You will go for hysterectomy? No, you will not go for hysterectomy. You will use these particular agents, GnRH agonist. These particular agents can cure the problem of the patient, but I have seen a very less gynecologist actually use these particular compounds because they lack the experience, right? If we talk about IVF and ICSI or intracytoplasmic sperm insertion, these are well advanced techniques to deal with the fertility. So, to practice this particular uh, techniques, you need experience and training, right? Contraceptive pills, everybody knows contraceptive pills, but how many of us can actually perform a hysteroscopic tubal occlusion, that is by Assure, right? So this is what I'm trying to tell you is um, a difference between what is super specialty and what is specialty. So because of we don't have that particular demarcation here, because we don't have much seats in the 3 years of DMs and MCH. Till then, the gynecologist only have to take a step forward and to learn a different and more advanced management protocols and treatment options for their patient. Right now, I will talk about something more practical. For example, if you want to be a fully fledged gynecologist in this particular time period in 2020, right? You must have this kind of knowledge these days if you want to run your own practice, right? So for obstetrics, along with the general obstetrics, you must be knowing how to perform a high risk pregnancy management protocols, for example diabetes mellitus, hypertension, and with IUGR. You must be knowing how to perform obstetric hysterectomy and internal iliac ligation along with the cesarean sections, right? And as a gynecologist, you need to deal with all the patient, all the kind of problems, but you must be knowing how to perform a hysterectomy laparoscopically, right? Laparoscopic myomectomy, diagnostic hysteroscopy, all this thing is actually needed in this day to day life of a gynecologist. A hormonal treatment, you want to start a hormonal treatment, then also you must be knowing certain amount of experience and knowledge, right? Infertility, a basic infertility everybody can do, basic ovulation induction basic everybody can do, but you must be knowing how to do a advanced ovulation induction with use of gonadotropins, right? This can also be done if you want. Color Doppler, ultrasound, that is very very important these days, and you must be knowing how to do this color Doppler, how to interpret the results, right? Ultrasound is a very very important investigation or a diagnostic modality for gynecologist. Is a Take it as a gift from the god. So USG becomes your stethoscope in gynecology, right? Because it is harmless, almost harmless. You can perform readily. You don't need to be reliable, or you don't need to depend on the radiologist for your basic diagnosis, because radiologist can at certain point of they can make a diagnosis, but it's only you who actually deal with day to day cases. For example, if the radiologist is seeing the uterus on ultrasound and you are seeing the uterus on ultrasound, there is the huge difference, because it's you who are going to remove that uterus if the patient is undergoing hysterectomy, and not that radiologist. So what I'm trying to tell you is, you must master this basic modality to run your practice, right? You must be knowing how to do a color Doppler, certain ANC ultrasound you must be knowing, like basic first trimester ultrasound, a growth scans, and like that. It's okay, you might not be knowing how to do a knuckle translucency scans and a target scan, that is a anomaly scan. So this is again becomes a field of radiologist, but and fetal medicine specialist, but basic USG a gynecologist must do. Gynec surgeries must be you must do, like ovarian cyst is there, cystectomy you want to do, adenomyosis, debulking surgeries can also be done by you. So to become a fully fledged gynecologist, these particular uh, skills are required. If you are thinking of opening your private small scale setup, you should have this particular facilities at your clinic, like basic OPD department where you treat the patient medically. You particularly have a ANC department where you deal with labor room, a cesarean OT, ICU or NICU. If you don't have those facilities, you can refer to a nearby ICU and NICU. A blood bank a blood bank setup. Many of the clinics don't have the blood bank setups. Even most of the clinics don't have a blood bank setup, but you must be having certain amount of uh, cooperation with the blood bank, right? For a gynec you need another, or that operation theater. For gynec surgeries you must be having the USG ultrasound machine, and uh, it is again, to have a ultrasound machine requires a lot of legal formalities in India, right? Now, what kind of experience, what kind of milestones, or what kind of career milestone you can have in your gynecology. For example, you must have to do a PG or post graduation from a good medical college. You can do a senior residency up to 3 years, because senior residency is very important. You can perform a jobs in private clinics, right? So this gives you the example how the public and private sector works, right? You must be having local supports, financial supports. You must be having a plateau time of 1 to 2 years where you can't expect earning too much, right? Another aspect is what the people join the medical college. Okay, they become assistant professor, then associated professor, and that professor. But this particular uh, um, uh, nature of job requires a different kind of mindset and a different kind of mentality, right, than the private practice. Because the professors and associate professors, they have to be uh, very kind of, what can I say, a scientific mindset, right, to perform different research projects and to run a teaching institute. So teaching is a very important part if you are joining a medical college. There are some career milestones. I have already told you. The first career milestone in obstetric and gynecology is basic obstetric and gynecology degree, right? You can have MS, DNB, or a DGO kind of degree, a basic obstetric and gynecology degree, right? Then you need to experience as senior resident, where you can become used to taking your own clinical decision, because transition from a student to consultant is very important. So senior residency provides you that amount of time and opportunity to transit yourself from a PG to a consultant, right? So where you can take your own decision, some decision you take on your own, and some decision you ask for your consultant, right? So this is how you learn to take the proper decisions. Then after doing SRships, you must be doing fellowships. You must be looking for fellowships. The life doesn't end here. The learning does not end here. Many of the gynecologists end their things here. It should be not done. You must be go for fellowship, because in upcoming times it is seen that it would be a difficult time for doctors in India, and at that time you will need skills for certain opportunities, right? You must be doing fellowships. The fellowships in the gynecology includes these: laparoscopy or endoscopy, high risk pregnancy, infertility, cosmetic gynecology, fetal medicine, urogynecology, oncogynecology, right? These are the fellowships or advanced fellowship that you must do after your basic course, right? You might be doing one or two fellowships from all this fellowship list I have described. You must be doing at least two fellowships, right? There is availability of teaching programs too, for example FNB, that is fellowship in national board, and DM. But unfortunately, again I told you, there is a very little demarcation, because people who get a FNB seat in infertility, they have 3 years, or let's say 2 years of time in doing this fellowship. But I have seen people that even after doing these 2 years of fellowship, they basically don't know, or they stay at the knowledge level only. What I am trying to tell you is, in the doctory, or if you do a practice, there are two different levels. One is knowledge level, where you know how to do certain procedures, and one is a experience level, where you already have done hundreds of those practice and you have expertise in that particular procedures. So I have seen people from FNB with 2 years of course. They, in infertility, they basically lack doing uh, their work or doing ovum pickups by their own, and they are not that much confident. So already we have those, and those FNB students, when they do a fellowship, they have to perform emergency duty for obstetrics department. Like, what I'm trying to tell you is, joining this FNB and DM does not make you uh, fully fledged doctor, right? Because what we have is, certain people, we have a mindset that yes, I will join this DM, or they go for super specialty examination and FNB examination, and they think that if they do this thing, they will be competent and they will be very very successful in the further market. No, it's not like that. Even after completion of this particular uh, courses, you must be practicing well, and you have more 1 or 2 years to master these specialties. Despite all the studies I have talked to you, let's talk about some another aspect. Two things ideally should be there if you have become a doctor. The first thing is work satisfaction and service to the people. This is the primary thing. You must be satisfied with your job or what you do, and you should or you must do a service to the society and the people. Another aspect is ethical monetary growth. Everybody wants monetary growth. It should be ethical and it is possible. If you do your work very patiently and you do a service to people, money will be the byproduct. So again, two things is required. So at the end of the lecture, I am going to tell you that even after doing your MS, MD, DNB, DGO, you must go for fellowships, because skill matters the most in private practice, while the degrees matters most in the teaching college or medical college. If you want to do your private practice, or if you want to get those renowned gynecologist status, you must be doing fellowships. Skills matters the most, right? Now here I am going to talk you what we can offer you. We are a 3G training center offering different kinds of training to the gynecologist, right? We have hands-on hysterectomy program in which we provide actual hands-on under observation of a uh, uh, experienced surgeon. We provide hands-on to the students or who have just passed out their post-graduate examination, or who are actually doing post-graduation, because we think that to understand the pelvic anatomy is very important, and uh, many of the gynecologists achieve this milestone unnecessarily late. It's not, it should be not that late, right? So with this particular things, I am closing my lecture, and I look forward for you for this to take part in this particular programs that we have, and I am hopeful that you understand my thoughts, and you will be very eager to join the training program. Thank you, friends.